um, so that we can talk. This week, we are really talking about a couple of things. And so just quickly, we're going to be preparing for our final. Now, the final's not the usual. Hello, Katie.
Sorry to disturb you.
No problem.
You went out this morning, right? No. Can you put your hand in the box and grab the first thing that you feel? Okay. Well, we'll see what the whole bunch of interviews today. On Wednesday at 5 o'clock before class, I'm doing a social for our students. A band, music, social. We're going to be in theatre. We're going to make some music. We're going to have some fun. So if you play an instrument or you sing, or you don't, now you do have an instrument, come and join us at 5 o'clock on Wednesday and come and have some fun with us. Okay? Cool. Thanks so much.
You're welcome, Katie.
My son might still use.
Pardon?
My son might still live.
Yep. Yeah, he might. We've had a lot of fun with those with our girls. The stuff this week that we're discussing really have to do with two things. Why we need reforms in the medical system in the United States, and whether or not the medical system is really a public health issue. And remember, public health is about the big programs that provide safety, protection, etc., from illness for the broad public. So the question of whether or not the medical system itself is a public health issue is not particularly irrelevant. In that if the system itself is inadequate, is not doing its job, then what do we do about it? And that becomes a much bigger problem. It's hard enough to get the medical system to look at itself objectively. Even those within the system that are trying to look, and one of the topics is that people are looking at is they're beginning to do something that scares the dickens out of a lot in the medical profession, which is really looking at outcomes research. In other words, all these things we do, are we getting any benefit of? Are the outcomes an improvement over doing other things? Maybe even doing nothing? And we see this as people begin to understand, this is my opinion, as people begin to understand issues like the overuse of opiates in trying to control pain instead of looking at other ways of dealing with that particular topic. And it's a difficult topic because pain is always individual. One person's stubbed toe is another person's the most excruciating pain they've ever felt in their life. And that's why even the pain assessment scales that we use are in many ways inadequate, because two people with similar similar injuries are going to have two different, very, very different responses to the pain and the other effects of those injuries. And some are just wired up funny and don't feel it. I think my mother-in-law is like that. I think she honestly doesn't feel pain until it is really, really bad. And that's not a help because, of course, the best time to treat pain is when you first notice it. And I don't mean taking drugs necessarily, although popping an ibuprofen or a Tylenol, that often will just set things aside long enough because pain builds on itself. So we have that. So the opioid crisis is a mess. But one of the things we see is just the way medicine is practiced in different parts of the country varies all over the map. Hey, Laura. And there was a noise like somebody coming online. Oh, we have someone else. All right. So, hi, Crystal. I'm glad you're on. I'm wearing a headset, so if you say something, no one else will hear it, and I'll just repeat it. So, welcome to class. So I was just talking about what we're going to talk about this week, which is the medical system and emergency preparedness and challenges for the future. That last one is a tough subject in a lot of ways because it all depends on where you think the future is going. But currently, the question on tap is the title to chapter 26, which is the medical system a public health issue? And if we look at what public health is about preserving the health of the public, preventing public health or health issues from arising. We think of it as preventing infections, but waterborne diseases and foodborne diseases, airborne, many things can be caused by not infectious agents. And so public health is concerned with those. And as I said in one of my posts in a discussion, the number of government agencies involved in areas that are related to public health, the environment, water, healthcare delivery, the VA, the Medicare and Medicaid administrations, these are all public health issues in many ways. And many of them are under the purview of a variety of different government agencies. And anytime you get multiple government agencies involved, you get rivalries, you get politics, you get all sorts of things going on. But one of the things that's happened, I was just talking to Brandy about this. Brandy Tao is the only one here tonight besides me right now. I'm hoping someone else comes in, but we'll see. Just telling Brandy that the medical profession is kind of jittery about some things that are going on now, investigating the outcomes of medical procedures and treatments. We were talking about the medical system as a problem, and we talked about opiates. There's been a lot of publicity lately about opiates. In fact, every issue of ARP's Bulletin and magazine has an article about opiates because the largest single group in this country being prescribed opiates, of course, is ARP members. It is older Americans. And it's because it's prescribed for degenerative type diseases. I mean, all of us, you get above about 30 and you've got arthritis. Some people, it's serious. Some people, it's not. I'm one of the fortunates. Yeah, my knees hurt now and again. But for the most part, not very much. And I don't have any of the signs of at least rheumatoid arthritis. Arthritis, as you know, is just inflammation of the joints. So we all have that. And in fact, you don't have to be 30. It can happen anytime. But pretty much anybody over about 30 is going to have some. So what do? We pop drugs. Do we change our diet? Do we change our physical activity? All of these things, those two things by themselves can do more to help these kinds of diseases than anything else. Sometimes you do require drug or other medical interventions. That's granted. There's no doubt about that. But the real issue is, instead of that being the last thing that people do, it's the first. And the other thing is that people will put up with pain until it gets really bad. Then they want something potent. When I learned a long time ago, I'm not prone to headaches. I don't have migraines or any of that stuff. But I know when, especially fatigue, I occasionally will get fatigue headaches if I don't sleep enough. And I know, I have learned through many years of making mistakes, that when I feel one of those coming on, if I pop a single ibuprofen or a single Tylenol tablet, it will dull it off and actually abort any progress of that pain, because the more it hurts, the more you think about it. If it's pain in a knee, the more you favor the knee, which then puts more stress on the other knee. You know, it's a never-ending cycle of reinforcement. Whereas if you can cut that off, you know, right away, then it often will take care of it. And that's what I found for me. Excuse me. Now, as I said, we have a lot going on in outcomes research. And lately, a lot of things that we've been looking at, especially with opioids, is the treatment of low back pain. Now, everybody has low back pain now and again. Most of us have low back pain because we do something silly, like lifting something wrong. And mostly that low back pain goes away. But there are low back pain events that come from injury, that come from accident. My wife, in her 40-year career as a physical therapist, is very familiar, and we've talked about this because we've had this problem right now with my mother-in-law. She was having low back pain, and it hurt a lot. And then for a number of reasons unrelated to that, we had to have her a low abdominal X-ray taken on her. And part of the radiology report was that there were, quote, old fractures of several of her lumbar vertebrae. Well, we got to thinking about it, and she started complaining about pain about a day after she fell and landed hard on her butt. And I mean, you talk about skin and bones. That's about it. There's hardly any muscle mass, especially in her right buttock. So she hit hard on bone. And so she had pain. We never even thought about opiates because we know from my wife's experience and her training that cracks, small hairline fractures of the vertebra, will hurt for about 6 weeks and then stop. And that's exactly what happened to my mother-in-law. If we had been, let's just say, my wife's cousin, my mother-in-law would now be addicted to opiates, because that would have been the insistence. Oh, we need to go get you some drugs. Taking them down, doctors would have prescribed opiates, and that would have been the beginning of the slide right there. So we need to have a better understanding, not just by the medical profession, but by people about these things. I know a lot of people who refuse to take opiates because they've heard all the publicity. I'm sure I know other people who take them regularly but don't talk about it, which is reasonable. Excuse me, I'm sipping some hot tea because my throat is bugging me today. So that might mean that I get quiet in a hurry because I'm going to run out of voice in a hurry here. Excuse me. But let's then take a look at some of the aspects of this, and I'm going to bring up a PowerPoint, and this is of chapter 26 in your text, which is the medical system a public health issue? Because the public health really is anything that is mandated by law in some ways. So we have certain mandates like prevention of the spread of communicable disease, like making certain that emergency services are provided. That's usually a local government issue. Hospitals, they in many ways are a part of the public health system because it doesn't matter whether you have insurance or not. You go into a hospital, you must be treated. There have been a number of lawsuits that have backed this up. Hospitals refusing to accept patients without insurance or sending them across town to the county public hospital. These have resulted in some fairly significant slaps to hospitals, both monetary and regulatory. So they have to. The VA system is a public health system. It's run by the Department of Veterans Affairs, but it's still a public health system. This, by law, is a right that all veterans have. Anyone with a higher than dishonorable discharge from the military has a right to medical care. Prisoners in our prison system, they're wards of the state. So not only do we have all these different levels of health, of responsibility, but levels of finance. Many of our programs in this country are old, but many of them are financed by either public funds or private funds, or a very long tradition we have in this country of charity care. The Catholic hospital system is a good example of charity care. We have public clinics. You have a communicable disease, or and that includes everything from the flu to sexually transmitted disease. You can go to a public clinic to seek help. How fast will you get it? Depends on the clinic. We have Medicare and Medicaid, which came into existence in the 60s after a very long and hard-fought battle. But we have a system that is multi-level, and the pay comes from our taxes, from charities, and from health insurance. We know about Medicare. All of you do. You've studied this. Medicare A is hospital. Medicare B is private care, etc. Medicare D is prescription drug. And then there is an unofficial, although it's used officially, Medicare C, which is basically combining all of those into one package, usually through an insurer. You pay for the Part A is covered by your Medicare part of your SSI contribution that comes out of your paychecks. Part B theoretically is voluntary, but you're really pushed into it. You pay for that directly to the Centers for Medicare and Medicaid Services. If you retire at age 62, you are, if you go on to Social Security early, you still can't get Medicare until you're 65, unless, of course, you're disabled. Medicaid is a state program. It's means tested. It's a cost sharing deal between states and federal. States have a big say over it. So the availability of Medicaid varies widely across the United States. The CHIP program is for families who don't means test into Medicare, but who need help for their children. As you know, all medical professionals are licensed by the states. So physicians, nurses, PTs, OTs, all of these people are state licensed. Now we've got, and the term physician in this case also includes doctors of osteopathy, DOs, who are a part now of a lot of group practices because they can pay them less, to be honest. The state regulates its hospitals and nursing homes. There is a national accrediting agency, the Joint Commission for Accrediting Healthcare Organizations, JHCAO, which accredits all of these things across the nation, but states establish those as well. And that accreditation is critical to getting reimbursed by insurers, by the government, etc. Our medical program has gotten to be extremely political. We all know about Roe versus Wade, the abortion decision, and what's going on now with the confirmation hearings for the new Supreme Court justice. You probably remember Dr. Death, Jack Kevorkian, who was advocating assisted suicide. He now himself has passed on. Lots of rules about right to die. We've had several major cases where Congress even got involved in making medical decisions for a patient, which really did cause quite a bit of trouble. Is there an obligation to provide care when it's futile? You know, it just blows me away, you know, and I'll get to why maybe it shouldn't, but it really blows me away when I read some expensive new cancer drug that I don't know what's going on. My voice is going, my tongue appears to be swelling in my mouth, and I don't know what's going on. So I'm not drunk. Okay, I know I'm beginning to sound it, but I don't drink, so, and I don't take drugs, so I don't know what's going on. So I'll keep going as long as I can, and then I'll stop. But it really does bother me when I read about a new and extremely expensive cancer drug that will extend life for a patient for an average of 2 months. And it makes me wonder why we invest hundreds of millions of dollars a year in these drugs that on average can extend life for a couple of months. Now, what that means is that some people it has no effect at all, and others may actually survive for a while longer, but nonetheless, is that worth it? Is it worth it to have a 95-year-old on dialysis? That's a tough question. I'm not 95 and I don't need dialysis. Am I competent to answer that question? Only for me at my age, which is, it sounds to me like dialysis is tough. When Bonfils down in Denver used to actually take my blood, they won't take it anymore because I lived in England too long during the mad cow years. But when they took my blood, I'd go in there and, I'd be lying on the table, losing a pound. And they had a dialysis center. And I'd see these guys get hooked up, and it did not look pleasant. It did not look fun. And these were guys who were my age. And so, I can look at it and say, well, if I needed dialysis and my first grandchild was going to be born in 6 months, would I want dialysis so I could see my first grandchild? I think the answer to that might be yes. But I can't say that because I'm not there. And I can't make that decision. The costs of these things are just unbelievable. There are a lot of ethical issues. Organ transplantation is another one. We don't have enough organs. And one of the reasons we don't is that the organ transplant program here is an opt-in program. When you get your driver's license in this state and many others, you're asked, do you want to be an organ donor? My view has always been, well, if I'm dead, I don't care what happens to my organs. I'm not using them anymore. And if they can help somebody else, God bless them. Let them have it. But a lot of people won't do that. In Germany and a few other parts of Europe, they don't have an organ problem, a transplantation organ supply crisis like we do, because it's an opt-out situation. You have to say no, otherwise the answer is yes. So, and people just won't say no. So they have plenty. Now, there's organ waiting lists. But I remember years ago, what was it? David Crosby, the musician, took so many drugs that it wiped his liver out, so he got a liver transplant. And then he needed a second liver transplant. And I looked at that and I said, you already proved that you couldn't handle the first one because you kept right on doing the drugs and alcohol, So should he have been allowed to have a second transplant? He was. And then he died not long afterwards. But there again, should that have been done? I don't know. I cannot answer an ethical question for someone else, only for myself. So anyway, one question, and Crystal, if you're actually on and able to hear, I know you're probably at work, but if you actually are on and able to hear, the question here is, do you believe that all Americans should have the right to medical care when they need it? So I'd like to hear what people think. What do you think, Brandy?
Some people don't qualify for Medicaid, so. I'll say this.
Okay. Crystal, if you're on, would you unmute, or if you can, and have anything to say, or you could just send a quick chat message. see what I've got. Okay, now, I'm sorry I didn't notice that okay, okay. You can use it. I've pulled up the chat, so you can use that. I'm going to go ahead and read this what you've just asked to Brandy, which is let's see, this was about 20 minutes ago. You wrote and said, "But if we change our diets, will it really prevent disease and cancer? Look at all the people who are on natural and organic, never smoked a day in their life, and have lung cancer." Well, okay, I'll comment on that. It is a fact of life that there are some diseases that are genetically linked. And although genes don't have to express, there is often nothing we can do about it. We have you have another statement here: organic, natural, and organic diet, never smoke. We have a friend down in Lafayette who is a vegan, who works out constantly. She's physically fit, and never smoked. And right now, she and her family are dealing with her breast cancer. And it's sort of like, okay, so you've had this natural diet that you've touted as disease, as helping you with disease, and it's not working. Well, these things happen, and she's not the only one, for sure. A dean down in Denver 5 years ago passed away from what is known as non-small cell lung cancer, or non-smokers lung cancer, and he never smoked a day in his life. But this particular type of cancer, non-small cell lung cancer, is extremely aggressive, and it is usually a death sentence. And he is one of those who was taking one of those drugs at the end that was going to extend his life maybe 2 months. And although I really liked the guy and I didn't want to see him die, I'm looking at it and say, why do you want to put yourself through this for 2 months? And it was because of his kids. He had young kids. So, yeah, it's not going to happen. Your next question, but who are we to tell a 90-year-old person they're too old to have it? That's one of my issues. I can say at my age, I can say, that's ridiculous. But if I were 92 or 95 and needing dialysis, I don't know what I'd say. That's a couple of decades in the future. And who knows? If I had a crummy life, if I was falling apart otherwise, I might say, oh, just forget it. But that's easy to say today. And again, I can't tell another person. This is why I could not be on a review panel with a bunch of physicians deciding who gets what treatment. We'll talk about rationing in a bit. And that's why I couldn't do it, because I don't like the idea of playing God. And since I believe that God takes us when God's ready, I'm not going to play that game. So, yeah, if it's not letting you talk, I'm not surprised. But go ahead and type anything you like, Crystal. I'm assuming you're hearing me because you answered these questions. But let's just move that. So that's what I wanted to look at there. And I'm going to go on now to let's see, what's this one? 27. And if I do new share, okay, so why is that not? Got it. All right, so let's go up to, this is the chapter about why the system needs reform. So we've all heard this before. the system, okay. Okay, I'm going to go ahead and read this, Crystal. The question about healthcare. Yes, I do think all should get healthcare, but I think organ donation is a different story. Okay. Are you willing to give us a little more detail on that last statement, please? Meanwhile, I'll go on and talk about other issues. Our healthcare bill in this nation a couple of years ago was $3.2 trillion, representing actually 20% or more of our total gross product, total expenditures in this country. And it's kind of a catch-22. The more expensive it gets, the less people use it. And so to maintain profitability and everything else, the providers of all services and care will raise prices. Okay, so I think they should keep screening, because if a person is an alcoholic, they do not deserve a new liver. Smoker does not deserve new lungs. Again, that's your take. I'm sure, and I know a lot of people agree with you. If you are causing the problem, why do I have to fix it? And I think that's a rational question to ask. And I'm not going to give you answers, my opinion on that, other than saying that's a valid thought that needs to be addressed. Who's responsible? If we simply hand you a new liver and you go out and start taking more drugs and alcohol again as soon as you get out of the hospital, well, you were a bad risk. And since it costs several $100,000 for a liver transplant, a bad financial investment by the society. Lungs are and lung transplants and stuff are again, we know that smoking causes lung cancer. So why should I pay for your new lung? Now, if you have a different condition where you're a young person, and this is a disease actually that does hit young people, with something called primary pulmonary hypertension, where the only therapy we currently have, besides basically keeping you alive temporarily, is a heart-lung transplant. That might be viewed as a different story. Here's a promising young life that might be able to contribute. And if the person is, if a person has a disease like that, they're probably not smoking, probably not spending a lot of time drinking either. But they're the ones that and it's a rare condition, but nonetheless, it is something that's there. So the question becomes, why are costs rising? Well, there's a lot of reasons. I won't go into them. You can look at the slides and see a whole list of reasons. One of the largest of those reasons, however, is an aging population, and what's not mentioned here is that doesn't take care of itself. We have a lot of people. I get appalled at seeing people who I consider significantly younger than me moving around grocery stores in one of those drivable carts. And I'm looking at it and I'm saying, why do you want to do that to yourself? Okay. Now, Crystal also added when I talked about people who have other causes for this. Different story in a way it was not a choice to do unhealthy habits. So yeah, exactly. But that puts a value on a life as well, which is also kind of a tricky thing to do. So again, that's why I could not function on one of those kind of review boards, because I would refuse to participate and make those kinds of decisions about other people's lives, because I don't believe I'm competent to do that. So anyway, but costs are rising because of a lot of reasons. Um, and some of them are legal reasons, and some of them are financial reasons. Every attempt in my lifetime, and we've been talking about controlling costs in the medical system for many decades now, every time it's been tried, it's failed. Putting controls on the costs can be done in a number of different ways. One is to simply not pay huge prices. I mean, if you get an MRI here in Colorado, it's going to cost you $300 to $500 minimally. If you go to Canada and get a scheduled MRI, it's like $50. The inherent cost of these things is very low, but the opportunity to use that as a way to really make money has been something that is tried. When we tried to control costs during the Nixon administration, which is back in the late 60s, early 70s, one of the things they did was they went into the certificate of need requirements to build hospitals, and they weren't giving them. And then then all of a sudden we found ourselves short on qualified hospitals, updated hospitals, and that's been removed now. And hospital building is going nuts. They're going up all over the place. Medicare tried a whole lot of different approaches to cutting costs, and those approaches ended up with many doctors refusing to treat Medicare patients because they lost money, in their opinion. The problem is every single one. Okay, now periodically I look over and see where Crystal's put another line here. So, but you might have to wait months in Canada to get that scan. Yes, you might, and then might be too late to do anything to help. Canada has a system. I mean, if you were in Canada and it were considered an emergency, it would happen. It is the elective stuff. It's things like getting an MRI on your shoulder to see if you need to have shoulder surgery. That can take you months, and then it might take you months to get the surgery scheduled. But if you had if you had extreme tenderness and lower right quadrant pain, the immediate suspicion would be appendicitis. And appendicitis is considered an emergency condition. You'd get that MRI and you'd get that surgery immediately. So it depends on why you're doing it. If that's been the sort of scare tactic a lot of people have said about the Canadian system and the British system. Elective surgeries are, we can schedule you in on the 18th Tuesday of next January, but an emergency, it gets taken care of. So it depends on how the system is set up. Okay. So we have our various. You've studied all these things: HMOs, PPOs, There was when managed care came in, there was a backlash because managed care was an effort to control costs. The problem is that there were several things that were done that were considered by many unethical. In that doctors would be given orders that they could not recommend procedures not approved by the HMO, by the managed care organization. They for a while we were pushing people out of hospitals way early. My wife, treating Medicare patients as a PT, would go in and spend an enormous amount of time getting a patient up and in the system and started on care, who then the next day would be back in the hospital because the patient was sent home too early. So then hospitals started getting fined for bounce backs. And that stopped. Okay, so but that was an effort to reduce costs. Consumers were demanded, and actually the Supreme Court agreed that they could sue their HMO for denial of care. Now, unfortunately, many times the suits never even went to trial before the patient died, and then the suit became a much different looking thing, but they still carried through. So the cost, the managed care wasn't able to really deliver, even though there was no clear evidence that patients were harmed by these things in most cases. So there's a lot of things that have been done. Right now, we know what we have. We have the Affordable Health Care Act. We know that we can't be denied care because of pre-existing conditions. There are rules that say if you lose your job, you can maintain through a more expensive form called COBRA your health benefits until you can move into a new insurance with a new job, and you have to be allowed in. So there's lots of ways that that people are looking at ways of dealing with improving the healthcare system, but we still have a lot of problems. We won't go through. One of the big things is experiments with rationing healthcare. People scream and holler about rationing. I remember one of the big arguments against expanding Medicare to the Medicare for All when it first started coming out was, do you want a government bureaucrat deciding on your health care? Well, the government bureaucrats decide on nothing. They do not get involved in healthcare decisions. But if you want rationing healthcare, how about some accountant at an insurance company who has decided that that they don't pay for these expensive procedures? These are not medical decisions. These are strictly financial decisions. And as a result, they are rationing. So another way to ration healthcare is to make it too expensive. Then you take out the bottom part of the society, and that's been going on. The slide here refers to the Oregon experiment with Medicaid. What they did in Oregon was they were looking at costs just going crazy, and they decided to look at medical procedures and made some judgments about the efficacy of some of those procedures. And then they said, well, some of these things we simply won't pay for. it's a little, you have to read, if you read the section in your text about the Oregon experiment there, you'll see that there's a lot more detail than I just gave. But what they did was they set up a hierarchy. Now, emergencies, appendectomy is one of the things that I mentioned earlier. Those, obviously, appendicitis, a burst appendix will kill you. So appendicitis is considered an appendectomy is a proven way of preventing further injury through a fairly straightforward surgical procedure. So of course that was on the list of, yeah, we do that. But less procedures with less perceived value or less real value were taken off. And, there's not a lot of details, but nonetheless, the effort to do that it really then forces patients and healthcare providers to think about to think more in the realm of how we can prevent these things, prevent you from getting certain things that are not covered for treatment. And so in a way, there's some benefit, but the word rationing, we're talking about rationing healthcare, not rationing gasoline during World War II. This is something that is a very emotional and political argument. And Oregon caught a lot of heat for it. And it worked for a while, and then the governor that pushed it was term limited out of office, and that's when it died. It's interesting that Oregon was also the first state that really approved a right to die law. They have a very progressive attitude there about healthcare, it seems. I don't want to do that. I don't care about that or that. One thing that is, if you really want to look at this, the Oregon Healthcare Health Plan website has some interesting information about that particular program. Okay, it's 7 o'clock. We're supposed to take our first break, and I want to stop talking for a little bit. So let's take 15 minutes. And so, Crystal, I'm going to pause the recording, but I'm going to leave Zoom on, and then we'll pick up in about 15 minutes. Zoom the recording. Talking about emergency preparedness. That's a public health issue. Natural disasters are public health issues. While many are predictable, such as the one that's coming to the Carolinas right now, Hurricane Florence, we know that's on its way. We can track it. We can predict when it'll land. The only variable is just how much damage it's going to do, but we know it's going to do some, if not a lot. So those are of the predictable sort. Earthquakes, volcanoes, and other things like that are not predictable. And yet they still occur. Technological disasters are a little different. They're unpredictable. And because they randomly occur. Principal example would be something that happened just today in the Pittsburgh area. There was apparently a huge gas line blow and explosion. That is a technological disaster. The Fukushima reactor that occurred some time ago in Japan, several years ago in Japan, was unexpected. All of these things are. Going back to predictable, sometimes the prediction cycle is much shorter, such as By the time we realized there was a problem 5 years ago with the flooding we had, it was almost too late. But people were warned, and some people were able to get away from the area. So we do have all of those kinds of things occurring. They produce all sorts of potential public health issues, from contaminated water to um, um, the destruction of animal life, and then the rise of disease that's associated with decomposing corpses, to all sorts of things that can get in the way. And we don't necessarily do a good job of handling those. Technological disasters, they also note here, can include things like terrorism. Again, hard to predict. And they could take anywhere from bombings to the release of biological agents. However, the general way of dealing with them is going to be very similar. Hello. Go right ahead. First, we get the people out, search and rescue. Then we worry about, treatment of those that we've managed to get out and have been injured. Food, water, and shelter for the people who are there. And then finally looking at the environmental hazards. So people first, and then the environment. But all of these require planning. I think we did a much better job in the World Trade Center attacks in New York in 2001 than we did a number of years later with Hurricane Katrina in New Orleans. And the first was totally unpredictable. Granted, there's some argument with that statement, but it was still unpredictable. The second, we knew it was coming. We knew it was nasty and did nothing to prepare. So there's lots of issues there. We won't go into that. We talk a lot about bioterrorism. We see this, and there have been a couple of things that have appeared. We had the anthrax attacks, which actually occurred just a couple of weeks after the World Trade Center attack in this country, traced back to a lab scientist who committed suicide. So there's no way to know for sure if he was responsible, but we believe that was the case. We have smallpox is the real fear. When I was a kid, we were all vaccinated against smallpox. When I went into the Army, we were vaccinated against smallpox. But nobody's immune anymore, unless it's people who are currently in the military or have been vaccinated within the last couple of years. But there are other agents out there that could be used. We won't go into a long list of them. They're in your book, and there are other things. But it's very difficult, again, to deal with that. If we look at this as being something that would be a terrorist attack, but it's no different than an outbreak of a very serious, deadly disease. If you've ever played the game Pandemic, it's a pretty good description of how to deal with the outbreak of disease, how to try and contain it. But there's a lot of problems with it. We're more likely to have a major deadly flu epidemic than a bioterrorist event. Fortunately, we are getting good at warning. The last couple of supposed pandemics have been dealt with well, have not really resulted in a really major event. However, that just should not make us complacent about these things. There's some questions here in the slides that we won't go into. So there's just a lot that we have to think about. What I want to do now is go on to the last set of slides that I'd like to talk about, which is challenges for the future. And the reason I want to do this is because, of course, this is the subject of your final essay. And if you look at week 4, there is a final essay. The final exam is an essay, a fairly lengthy one for one of our classes here, but nonetheless, it's an APA format essay that we'll talk about when I get done with this chapter. The 20th century saw some remarkable changes in public health. Widespread vaccination, cleaning up the food supply, cleaning up the water supply, really getting people to think about personal hygiene. Early in the 20th century, and in fact, in 1925 in Nebraska, a doctor went to deliver the 4th child of a woman, a farmer's wife. Delivered that child. The wife, the mother, developed childbirth fever, puerperal fever, we call it, 2 days later, and a couple of days after that, she passed away because the doctor didn't believe in washing his hands. Now, the germ theory by this time was some 80 years old. And we knew since the 1840s that we could reduce childbirth, both maternal and fetal mortality, by the simple act of washing hands before assisting at a birth. But this guy didn't believe it. Didn't believe in washing his hands. It's not necessary. So, and I know this story because it's the story of my mother-in-law's mother. She was the one who died. So one of the things that we have is come up with better ways of making sure that childbirth is much safer than it used to be. Is there still maternal mortality? Oh yeah. But the rate now is very, very small by comparison with what it was a century ago. So we have gotten better. Another way we've dealt with that is by improving contraceptive, by having contraceptive techniques to prevent pregnancy. Pregnancy is not a disease, but it can kill you. So we have these. We have better ways of controlling infectious disease now. The antibiotic revolution has been a Pandora's box. It has had its dark side as well as its light side. The dark side, of course, being one of the challenges we're going to have in this century, in the 21st century, which is dealing with resistant microorganisms. And organisms we thought we had under control are now showing up as resistant and causing problems. We have cleaned up our water, not just fluoridation. Fluoridation is good for your teeth. What it does is it helps resist the effect of certain bacteria that cause dental caries, but also strengthens them. And then lastly, the recognition of tobacco as a health hazard, whether or not that's whether or not Kathleen Sebelius's idea that we will do away with smoking within a generation, I don't think that's going to happen. But it's reducing. We're making progress. What are the other things? Well, we've already talked about resistant infectious organisms. Climate change. Climate change is going to have so many broad effects on food production, on water supplies, on population and location. There's always argument as to whether this is true or not, but we see every bit of evidence that sea levels are rising. Well, where does most of the population of our world live? At sea level. As the seas rise, they're going to go upland and inland where they're not wanted. So there's going to be lots of conflict. That's public health. How do we deal with it? How do we plan for it? As lives keep extending, and we're working very strongly at that. I mean, there are companies that are working on what are touted as promising treatments for aging. Whether or not they're going to work, who knows? But I saw one of the products being talked about on a shelf at a health food store recently, resveratrol. It's supposed to be the longevity compound that is isolated originally from red wine grapes, but not proven yet. All the studies in rats and mice have not been borne out in humans, but humans live a lot longer. Rats and mice in captivity will live about 2.5 to 3 years. Humans cared for should live a lot longer than that, 20 or 30 times that long. So it's hard to prove. But we need to look at our behavior. Part of it is smoking. That will help reducing that. Alcohol is another major problem, health problem. It causes a lot of issues. But our food supply and the foods we eat are really, really, in many cases, very unhealthy. Now, I'm not saying you should never go out and eat a hot dog, but it shouldn't be your prime diet. You should, we all know that. And what we see is a growing set of disparities in health among the wealthy and the less wealthy. We can see a spectrum. Better off people financially and have access to health care and in general are healthier than people who can't afford it. The logic of that is real obvious. It's what we would expect. But nonetheless, is that right? No, it isn't right. And the public health system itself needs to be strengthened because with these changes, aging population, climate change, infectious disease, public health is going to become much more important to the health of the planet. And so that needs to be just strengthened quite a bit. I'm not going to talk about some of these things, but there needs to be a better liaison between the medical care side and the public health side in order to really to get away from the treatment model and go more toward the prevention model. Prevention is more public health than treatment. Doctors will always tell you the same thing. Well, prevention is cheaper than cure. I cure. Well, let's talk about how your practice can help people not get sick. It's going to require some changes. And a lot of those are going to be are going to be looking at the mission of public health. We've seen information technology changes. You've seen them in the last few years, with now the widespread use of electronic health records and all these mobile apps that we can get to track our health. Many of them are charlatans, as far as I'm concerned, but a lot of them are actually pretty good. Again, it's a case of really going through and looking at what's available instead of just loading up your phone with apps. Look and see what can actually help you, because in many cases the apps might be great for me but lousy for you, and so you need to look at what's useful for that. A lot of these things, communication and data sharing, there were times when public health offices, in states wouldn't talk to the government. They couldn't be bothered. Now there is real close collaboration as we see the spread of disease becoming much more facile with transportation and with communications and so forth. These things are there, and some of these will be a major challenge to integrate into our society. We already know that electronic medical records can help us coordinate care and can help us have a decrease duplication of services. We're seeing now, even though it's been a tough sell, we're seeing now that it's becoming harder and harder for people who are seeking opiates to go bouncing from ER to ER to ER and getting prescriptions, because they're communicating. If that prescription goes into the system, there's an alert that pops up and said he just got a prescription for this stuff an hour ago at Hospital X. So we're starting to see some impact of these things. As I say, it's been a bit of a tough sell because, of course, HIPAA gets in the way. But it's logical to say that if you go in and ask for a prescription, say for OxyContin, it is actually HIPAA compliant for someone to say, has this person had a prescription recently? It is within the HIPAA rules. You can ask that question and get that information. But one of the biggest problems was cross-platform communication, and now they're dealing with that. So the real challenge is going to be, how we can integrate these things to affect what's going on. And then there's technology. Biotechnology is a term that's been around for a long time. The issues uncovered by our decoding of the human genome have had some interesting ramifications. The ability to modify the way our cells work. I was just reading an article from Northwestern. My wife's a graduate of Northwestern University, so we get their medical center magazine every month. And I was reading an article in there about a gene therapy for a hemoglobin condition called beta thalassemia, in which the hemoglobin is incapable of properly absorbing and releasing oxygen. And so it leads to a really serious anemia and deadly. And the only treatments in the past have been multiple blood transfusions, like about every 6 weeks, going in for a blood transfusion. Well, the downsides of transfusions are tremendous. And so Northwestern developed looked at what was causing the problem with hemoglobin, identified the gene responsible for this, and then took from thalassemia patients their stem cells and genetically modified those patients' stem cells to put in the proper gene, and then reinfused those stem cells into the patients. 70% of those patients no longer need transfusions. And most of the rest have seen their transfusion need drop by at least 50%. So we have really some really fascinating possibilities. But we also have things going on like efforts to clone human beings, being not being done openly here in the United States, which is not to say that somebody's doing it and I just don't know. I don't think people are. I think there's a lot of ethical issues, but there are other places in the world that don't share those ethical issues and have been working on cloning individuals. One of the other aspects of is individualized medicine, being able to look at a patient, do a genetic analysis, and say, this is the medicine that they will respond to. We're getting more and more information about that. But the expense at the moment is hideous. And that's one of the challenges is, can we afford to do this? One of the things that that we need to think about as well is, how do we deal with the extremely high cost of drugs? When Medicare D was passed, one supporter of the drug industry in Congress slipped in a provision that forbade the government from negotiating price with the drug companies for Medicare. Now the VA already does it, so there's precedent. But this particular member of our Congress slipped that in there, and it passed. And then he left Congress and got $1 million a year drug heading the Pharmaceutical Research and Manufacturing Organization. So he feathered his nest at the expense of the public. And so many efforts are being made now to find ways to reduce the price of drugs. And there will be many, many others. Some of them are going to end up in court. It's going to be very interesting. But we need to have, we need to really talk about where we want health to go in this future. Okay. So I'm going to stop there on that one as well. We'll do a new share, and I want to have, good. I want to have that. And then I want to go to look quickly at the final assessment. I sent out an email over the weekend. I presume you got it, which I was talking about what we have yet to do. The final assessment is the big project this week, a 4 to 5 page paper. And the topic is, although the 20th century witnessed great strides in improvement of the public's health, the future of public health will continue to face challenges. For this assignment, you are to examine the future of public health. What challenges will we face, and what challenges have yet to be resolved? What methods will be effective in dealing with public health issues? And as a healthcare manager or administrator, what is your role in the future of public health. So this is a serious effort to have you think about where public health is going. What will be, when you're out there working in the field of healthcare administration, what are the public health issues that are going to be dealt with? You may find yourself right in the middle of them. You may find yourself on the periphery. But nonetheless, if you're in healthcare administration, they're going to affect you. So that's what we want. That's what you need to be doing. I mentioned that the very first day of class, that we had this final that was not our normal final. It's not a bunch of questions to ask. So you need to get started on it. And what we'll do is we'll meet here again Wednesday because we have to. But I think other than answering questions, we'll probably spend our time working on this assignment. Now, I'm going to tell you something. As of Wednesday, all of the daily checkpoints for the rest of the week will open up. So you can finish them all. Now, they will sequentially close when they're supposed to. Wednesdays will close on Wednesday. Thursdays will open Wednesday, close on Thursday. Fridays will open Wednesday, close on Friday, etc. So what I'm suggesting is that you can get them all out of the way, because I'm trying to help you do your best to get at least a longer weekend before you have to start up next month. But that's what we're going to do. Okay? No discussion this week. No. This is enough. Okay? Usual, I'd like several references. Use the databases that we have in the library. You know how to access Shark. So you can read these things through there. Peer-reviewed journals are in these databases. You don't have to have yours peer-reviewed, right? Okay. So my voice is about to give out. So we're going to stop, and I'm going to let you, Brandy, you can continue to work, and we'll just stay here till about 8:25, 8:30, somewhere along in there, and then leave. Crystal and Brandy, you don't have to do this, but other people who look at this video that I will be posting later on, I want you to send me an email, and in that email, the word I want is Kerala, 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 and that'll tell me that you've listened. If you have questions, email me. If you have assignments still to do, get them done. Crystal, I hope you are able to do the other assignment we emailed about earlier, and just get things in. As usual, if something happens and you find you can't submit something, email it to me and let me know in the title that you're emailing an assignment. Okay, that way I will get it. Now I have to close out some of the assignments. I have to assign grades. So if I've already put a grade in an assignment for you and you submit an assignment, let me know. You can still submit, but let me know. That way I'll know to go check and take care of it. Okay? So I'm going to say I've had it and I need to quit. And I will hopefully see you guys on Wednesday. I'm not sure we're going to be doing a Zoom session, or if we do, it'll be very, very short. But I will see you on Wednesday for the final. And now I am stopping.